One of the valuable contributions to the obstetrical armamentarium has been the Barton forceps. It is a highly specialized instrument chosen for use in a very limited, select group of patients. This forceps is probably the least used and the least understood of the special forceps. Dr. Edward H. Dennen, consultant to the Surgeon General of the Army, has been a staunch supporter of the use of this forceps and has been responsible for much of its popularity in the country today. Dr. Dennen.
Thank you, Colonel Reaver. In 1925, the late Lyman G. Barton of Plattsburgh, New York, presented this instrument. The original indication was for transverse arrest in upper pelvis of a flat pelvis, particularly ahead in posterior parietal presentation. The very situation in which there's no other instrument in general use which can be used with safety on this type of presentation. Subsequently, the indications were enlarged to include deep transverse arrest, particularly those with the deformed sacrum, shortening the AP diameter of mid-pelvis. And also, by some operators, it is used on posterior positions. And then it can be used to an advantage in face presentations. In the construction of the instrument, they find something quite unique. One blade is attached to the shank by a hinge, allowing the blade to rotate over an arc of 90 degrees. The other blade is attached rigidly to the shank with a marked angle. Both blades are attached to the shank with a lateral angle, so that when the instrument is in the anterior position, there's no available pelvic curve. However, when rotated to the transverse position, the pelvic curve is perfect. The instrument has the sliding lock, and in addition, there's a traction bar for axis traction. Again, the advantages of this instrument depend upon the various points in construction. The hinged anterior blade, and there's no left or right blade to the Barton forceps. The hinged blade is the anterior blade and is applied first in all instances. And the posterior blade is the rigid blade. Because of this hinged blade, one can obtain an easy, accurate application by the wandering method, carrying the blade up under the symphysis, opposite the anterior ear. The lateral attachment of the blades to the shanks gives a perfect pelvic curve when attached to heads in the transverse position, allowing traction in the transverse to the outlet before anterior rotation is carried out. The technique that is necessary in the mechanism of the descent through a platypelvoid pelvis and also past a deformed sacrum. The sliding lock permits locking of the handles at any level and allows for correction of asynclitism. And the traction bar gives excellent axis traction. The disadvantages. disadvantages deal mainly with the type of pelvis. They are the android and the anthropoid pelvis. In these situations, the head must descend in the AP, or the anterior oblique, or posterior oblique position. This instrument is not built for that purpose. It is constructed to cause descent in the transverse. And when applied to an anterior head, there's no available pelvic curve, and the advantage of the axis traction is minimized. So that it is undesirable to use the Barton forceps in android and anthropoid pelvis. A minor disadvantage is after descent in the transverse and rotation to anterior. Because of the lateral attachment of the blades, there is no pelvic curve, and it is awkward to gain extension over the perineum with the handles directed obliquely away from the long axis of the patient. Introduction of the first hinged blade of the Barton forceps for LOT with partial extension. Both fontanelles can be felt with equal ease. The handle is held in the right hand, and the index and middle fingers of the left hand are at the heel after guiding the toe of the blade directly posterior to the head. The hinged Barton blade has been wanded by the index and middle fingers of the left hand around the right side of the pelvis over the face of an extended LOT to the anterior right ear behind the symphysis. The right hand on the hinged handle changes its level as the blade approaches the anterior ear. Introduction of posterior rigid blade of Barton forceps between the handle of the anterior hinge blade and the right thigh directly to the posterior left ear of LOT. Application of Barton forceps to LOT. Any asynclitism had been corrected by equalizing the handles. Front view of Barton forceps applied to LOT. The head is now ready for traction in the transverse and is brought down to the outlet before anterior rotation can be accomplished. Side view of Barton forceps with axis traction handle ready for traction on LOT. Anterior rotation is not done until the head has been drawn down near the outlet. Barton forceps on LOT. After the head has been drawn to the outlet, preparatory to counterclockwise rotation to OA. Barton forceps on OA after descent and counterclockwise rotation from LOT to anterior, ready for traction and extension. The handles are directed obliquely away from the midline toward the right thigh. Here we have a head arrested near the inlet in the transverse position with partial extension and the posterior parietal bone presenting. The anterior hinge blade is applied first by wandering it around either the side of the face or the occiput, whichever offers the least resistance. By experience, we've found that in heads of this sort, especially with partial extension, wandering it around the side of the face offers less resistance than around the side of the occiput. In flexed heads, the direction of choice is around the occiput. But since In flat pelvis and in deformed sacrum, the head is usually partially extended. That is, one can feel both fontanelles with about equal ease. Most of the indicated cases for the Barton, the blade is wandered around the side of the face, starting posteriorly and wandering all the way around, directly anterior. The posterior blade is inserted between the handle of the anterior blade and the patient's right thigh, directly along the sacrum. The handle of the hinge blade is lifted to locking position, and as the handle is compressed and the handle's equalized, the asynclitism is corrected. Then traction is given into this transverse position all the way down to the outlet before anterior rotation is accomplished. After reaching the outlet, the rotation in an LOT is counterclockwise over an arc around to the anterior position. Then, delivery is accomplished by extension of the head over the perineum. As soon as the chin can be reached for the Ritkin maneuver, the hinge blade is removed, followed by the removal of the fixed posterior blade. This will be repeated inside. Again, experience is taught that it isn't always necessary to insert the hinge blade directly posterior and wander it all the way around half a circle to anterior. Often it can be inserted directly to the side. In this manner, the posterior frontal eminence is avoided during the rotation. The index finger is placed on the blade near the hinge, and the hinge is wandered around to anterior. And it's left in place, and the posterior fixed blade is inserted directly posterior along the whole of the sacrum, being careful not to depress the handle lower than 45 degrees above the horizontal. That exaggerated curve to the fixed blade prevents lowering the handle to any lower level. In order to lock them, the handle of the hinge blade is lifted up into locking position. The handles are at an unequal level, but that's the asynclitism, which is corrected by locking and equalizing the handles at the same time as correction of the asynclitism. And the head, which previously was at the high level because the anterior parietal bone was above the symphysis, although the posterior parietal bone was down at mid-station. However, after correction of the asynclitism, the anterior parietal bone is now at a level of the posterior, which is mid-pelvis. Then the traction bar is attached. The operator seats himself and begins traction directly in the transverse. Traction bar is resting the upturned palm of the right hand, the left hand on the handles to direct the elevation with descent. Directly in the transverse, all the way down to the outlet. course, this couldn't be done in an android and anthropoid pelvis because there's a lateral contraction from side to side in those pelvises, preventing descent in the transverse. However, with the platypelloid and usually with the deformed sacrum, there is no transverse contraction. In fact, it's often wider than in the average case, all the way to the outlet. Then, as the leading bony part appears in view, the rotation is begun. And in left side positions, it is counterclockwise, from 3 to 2 to 1 to 12. The handles are elevated, the traction handle up, over, around, and down, and the occiput comes in view under the symphysis. And we're ready for extension. Occasionally, especially in primipara, it's necessary to remove the forceps at this stage and replace them with a Simpson type with axis traction in order to get extension. This lateral divergence of the handles to the patient's right side, away from the long axis, makes extension difficult in certain cases. But with the generous episiotomy and descent of the occiput into view at the outlet before rotation, most of these cases can be delivered with the Barton forceps if the head has descended into view at the outlet before extension is attempted. After the Ritkin maneuver can be carried out, the hinge blade is removed, then the fixed rigid posterior blade is removed with the handle below the thigh. It's considered undesirable to use the Bartons on posterior positions because the advantages of the Keelan are so much superior to the Barton.